Let's just get my timer up. So hopefully this will follow on fairly well from that. I'm going to talk about the TRANSFoRm project, which is, can you hear me all right back? Yeah, good. An EU FP7 project, which is now in its 4.5 years into a 5.5 year project. That's our website, so there's plenty of additional information on there. €7.5 million project. It actually finishes in November. We had a slight extension. And it was funded under the Patient Safety Work Programme of FP7 with 3 things in the call document: to support clinical diagnosis and support clinical trials as part of a rapid learning healthcare system, as it was called at the time. It has 21 partners from 10 EU member states. So a fair old smattering, and it's very, very multidisciplinary. Clinicians, clinical researchers, experts in informatics, ontology, data standards, terminology, computer scientists, everybody, psychology. So it's been an interesting few years. What the project sets out to do is to develop methods, models and services and validated architectures and demonstrations to support 3 things. We call these our 3 use cases. So epidemiological research using primary care records, so phenotype, genotype studies and other record linkage. Research workflow for randomised trials embedded in the EHR. So 2 things on the research translation side and 1 on the knowledge translation side, which is decision support for diagnosis. So it's a different kind of decision support than John has been talking about, which is decision support for guideline implementation and interventions. Each of these has a particular question. So the diabetes one, or the use case 1, is around the relationship between SNPs and response to oral antidiabetic medication. It's a case control study. And the RCT is in gastroesophageal reflux disease, and it's about with the principal outcome measures being quality of life and symptom score for continuous versus on-demand use of a proton pump inhibitor in gastroesophageal reflux disease. Come on to that in a minute. And decision support for diagnosis focuses on 3 places where we know from previous work that GPs make mistakes: chest pain, abdominal pain and breathlessness. They are common problems with wide differential diagnoses, some of which are quite serious. And we've based this on using the evidence of clinical prediction rules as the underlying service, feeding a peripheral decision support system. So I'll come on to that in a second. So I'm going to focus on some key informatics challenges. The first of all is loss of meaning without the system. If you don't have a learning health system, the knowledge that is created at various parts around the system simply disappears into the ether. And specifically, what's available currently in electronic health record systems doesn't reflect what took place in the patient encounter. Because doctors use codes differently, code to different extents, may not code at all. The absence of a condition is hardly ever put in the record, even if it's clinically important. There's all sorts of issues around cardinality and use of different terminologies, different mappings. They certainly don't map to one-to-one, and even if they do, it may not even be the equivalent concept which does. And there's also the loss of context in which a particular clinical observation takes place that gets stripped out and lost from that record. So the kind of work that's going on at the moment around use of routine healthcare data, CPRD, Q research, it's barely scratching at the surface of the potential for the information that really is present there in the healthcare system. And it gives a very, very partial and potentially biased view. So take, for example, blood pressure. A blood pressure reading in a record could be a clinical observation. It could be an interpretation of raised blood pressure or normal blood pressure, or it could be the basis for a diagnosis of hypertension. And in any case, it's context dependent, and it's a 2-part data element. It's got a systolic and a diastolic, and different record systems have different ways of dealing with those. You then have the issue of heterogeneity. We've touched on a bit of that already. So access to underlying health record systems will vary from none at all to plundering that underlying database to having a fully featured application programming interface where you can do things with the system and call it up. The data structure, the way the data is stored, will vary. The terminology may well differ. And text itself, I think, is the ultimate heterogeneity challenge. How do you interpret a piece of text information? In terms of standards themselves, there are many different standards. I don't quite take the view that there's as many standards as you like. Which one would you like? But they're all built for different purposes. But there are, I've listed some of them here, but there clearly are good examples of turf wars between different standards organisations which carry on to this day. And I think the learning health system will have to deal with those. Now, within the learning side of things, we have CDISC, the Collaborative Data Interchange Standards Consortium, which is essentially set up by the pharmaceutical industry to develop standards for the representation of clinical trials, data, etc., of which the operational data model is one of the most important, and it represents a way of presenting information that can be structured and created into a template or a form. So it's very, very important for that data collection side on the clinical trial use case. But it operates really as a data interchange standard. It's a holder which contains a wide variety of content. Therefore, what you put into it can vary just as much as things in the record system itself. There are attempts to standardise this a bit with CDASH, which assembles libraries of well-defined forms, data elements and things which you can use as standard ways of collecting certain pieces of information through a clinical trial. What TRANSFoRm does, and I'm picking on the trial one as being a kind of exemplar of what it does throughout, is it uses references to standard data models expressed as ontologies to maintain meaning across the whole system. So an ontology goes, if you think about a classification as being a hierarchical set of relationships between clinical entities, an ontology goes further than that, and it specifies properties and commonalities between those different entities in that structure and enables a computer system to reason new information about existing knowledge about relationships that already exist between known entities. So an ontology is a rich representation of structure and meaning that can be used to maintain learning in a healthcare system. So we've chosen ontologies as being core. Now, archetypes, OpenAir being a very good example of using archetypes. Archetypes give a standard pattern or template or format, a way of structuring individual data elements such that one model of meaning can be constrained either by a more detailed version or against another model of meaning. So in TRANSFoRm, we constrain our clinical meaning against our research meaning. So we have this dual representation of things. So what we have done is to essentially define an archetype for representing data elements for research and clinical use and place this as the payload within the ODM structure. So it's extending the ODM structure and making it maintain the meaning across the system. So now we have the issue of heterogeneity. Well, if you've got an underlying common model, then you can map your disparate data sources to that common model, and you can do this peripherally. So we have a data node connector, which is the interface between any database and any electronic health record system, and manages mappings between terminologies and structural data mappings between target data sources and our common reference models. Over and above that, we comprehensively use the available standards, particularly from CDISC, reference terminology, and then the standards around ISO 13606, particularly archetype definition language. Now, I think this is fundamentally what the learning health system is about from an informatics perspective. It's about building a software platform that's built using tools to author, exchange, and act upon basic information constructs, of which I've given you a set of examples of how these strong constructs can be made. And those common constructs serve all three use cases for TRANSFoRm. So it's trying to create a generalizable way of dealing with heterogeneity and models of meaning throughout the healthcare system. Very briefly, we have tools for the RCT, the epidemiological study and decision support. We have a set of middleware services such as authentication, data transport, provenance, tracking what's happened, and then the data source connectivity. So for example, if you're looking at model-driven data connectivity, you have down there the data node connector, and starting there with our green box, our clinical research information model. So what is it we're trying to find from a clinical research point of view? Is this a study outcome? Is it an eligibility criteria, etc.? That's used on a workbench where it's integrated with a clinical data integration model. So our model of clinical use, which would contain diagnosis, lab test observation, for example. Those two concepts are put together and bound with a specific piece of terminology. So we've got these two broad concepts, and we're going to specifically look for the read code for blood pressure as part of that. This is then passed down to the data node connector, where it's locally mapped to the source. So what does it do for the RCT? Well, it's capable of extracting study data from an electronic health record to facilitate data entry. So it will create a form in a tabbed browser for a health record system and pre-populate it with information that's been run on a local search in the EHR system. So avoiding duplicate data entry, pulling up information on demographics, prior history that's relevant, whatever you want to do to run that query. The physician then is asked to complete the study data entry that's not present and to confirm that which has for GCP purposes. And all that information is then saved into the electronic health record, structured in a way that would be captured in the EHR, and where it's not, the additional information is stored as a technical term, a blob apparently, a piece of information which can be queried by our system but is just kept in the EHR system, so it can serve as e-source. We've got great store on the use of standards and interoperability technologies, so ADL, study data models for workflow, and the operational data model, which I've talked about. So, for example, imagine that you have an envisaged sort of document which might have been represented as a paper questionnaire. In our case, it will be represented as an XML document, structured according to CDISC ODM, with carrying the archetypes for the individual data elements. This is then passed into a data collection server, where it could appear in a health record system, but it can also appear as a web interface, and for patient-related outcome measures, it appears through an app on an iPhone or an Android device, which looks just like this. So you can do click-down patient-related outcome measures collected directly from patients through mobile devices which they're carrying. So it fulfills one of the requirements of our trial, which is to have this area under a curve of quality of life between the two measures. In 2 minutes, I'll talk briefly about diagnostic decision support. Think about this in the same context. Here we have now a library of information. We know that the diagnostic information can be structured in different ways, but like a kind of hierarchy of information through clinical prediction models, which could be simply counting the number of elements that are present in a history, or actually right down to a full Bayesian score with interactions, everything. There's quite a variety of these different rules. But they are really the means of encapsulating knowledge for diagnosis. And we need to match this with information that's being collected by the clinician and to support clinical diagnosis. I'm not going to talk about it now, but we've done a lot of work around where, from a psychological perspective in workflow, we can intervene to improve the diagnostic process. And we focus very much on early intervention. So if you prompt people to think more widely at the very presenting point of the patient, we've shown in some experimental designs, RCTs, that you actually improve accuracy because people ask better questions, they ask wider questions, and they close down less early. So suggesting potential diagnoses based on a reason for encounter, matched up against the frequency for that individual patient, is our intervention. At the same time, we want to collect better information. So we actually want to code the symptoms and signs so we can mine the data to create better clinical prediction rules. So we have a dual purpose here, both capturing better information and changing the diagnostic situation. So we have the health record system at the top, the clinical data information model based data connector linking with decision support tool, with the clinical evidence service, and the prediction rules based on an ontology of diagnostic evidence, populated by information from data mining and interacting in real time during the consultation. So here is actually, if we've got we don't have a thing, but in the background is the In-Practice Systems Vision 3 electronic health record system. So we've been working with them. They've put a little red button on the top. You press that and it brings up a small window that says what's the reason for encounter. You put in the reason for encounter, in this case abdominal pain, and the system then queries the ontology, pulls information, queries the record system through the API, finds out age, sex and previous comorbidity of the patient, and pulls out a list of potential diagnoses. Initially puts them in a box at the front and it disappears to the right-hand side. This bit, signs, symptoms and evaluations, we collect structured coded information about all the other things that the patient has. And these are suggestions driven by the ontology, so it's not just a predictive text, it's an ontology-driven symptom collecting information. And as you collect information there, that list of diagnoses changes, shuffles up, things disappear, and so you get a real-time interaction. And you can also delve into, you can click one of them and it drops down and tells you the rules that are under operation. You can actually answer the question directly if you want to. We're currently 2/3 of the way through into recruiting 30 GPs who are doing a control before and after study with simulated surgeries with actors and highly structured clinical problems to evaluate this, principally for its direct effect on accuracy of diagnosis, but also on usability, etc. Thank you. So that's TRANSFoRm. I would add probably two things quickly. We are also doing the real RCT for reflux disease in 5 countries with individual randomisation and a cluster randomised nested evaluation of technology versus standard web-based sort of remote data capture. And we're doing an evaluation of the linkage of different databases across 5 countries as well. Thank you.
Thank you. Gives a great impression of what can be possible in the learning health system, but also how difficult it is to actually implement in the real clinical setting.
Yeah.
Any questions?
Thanks, Brendan. Just give you an idea of the scale of the clinical trial that you're setting up as your test bed.
800 patients in each group, individual randomisation. So 800 to continuous treatment, 800 to on-demand, recruited across 5 countries, 10 practice sites, medium-sized practices in each country, of which 4 will use the TRANSFoRm system and 4 will use just a web-based data collection form we've set up. So that's 20 sites in each group.
Just briefly, I haven't sort of completely grasped the role of the ontology here, but can you give me an idea of what reasoning you're using the ontology for in the context of this data?
The reasoning side is really on the decision support side. What we're using the ontology for on the RCT is to bind high-level structural concepts commonly across the project. So we have a data element which would consist of a string of XML, and in the carrier where it says, and here in the ODM is the data element part, we're using then the archetype definition language to internally reference the data type to the ontology, both for what kind of data it is for the research point of view and what kind of data it is for the clinical point of view. So if you're looking at a blood pressure measurement, for example, it would say it's a clinical observation and it's a follow-up data element for the clinical trial.
So this goes beyond sort of metadata into some sort of high-level workflow kind of...
Yes, yeah.
Is the archetype definition language open air?
Yes.
It is.
Yeah, it's using the open source tools for that to define them. The gap in the project at the moment is that each of these constructs, the ODM, the archetypes and things, have to be handcrafted with reference to using some of the ADL tools, but they have to be handcrafted and linked. The next step would be to create a set of workbench and a way of creating and archiving the different data elements and things, but that's something that has to come on after that project.
Have you considered, or is it within the scope of the project, what would happen if you were to take it and integrate into another EHR system?
Well, we're integrating with 5 different EHR systems. So we're using TPP and In Practice systems in the UK, Asseco in Poland, a kind of homegrown EHR system in Crete, and a system in the Netherlands called TRANSFoRm.
They're all primary care.
They're all primary care, yeah. But there's nothing ostensibly primary care about this. I mean, the principles could be applied in any domain. Yes, so the products are directed at primary care. And in the UK, the intention is that they'll work with CPRD and the work that CPRD is doing with its clinical trial work, which is something we've been talking about for a couple of years, and CPRD are part of the project. I need to go and talk to Janet Valentine the week after next about actually getting that done.
You didn't say EMIS.
We're not actually directly working with EMIS, but at the moment we should do.
Do they have an attitude?
Well, we talked to EMIS about wanting to do a decision support system with them, and they said we've tried decision support before and it doesn't work. Yeah, they do have a bit of an attitude, but I think it will change.
Shall we take one more question and then?
Out of interest, how do you actually deal with the heterogeneity of both the structural format of different systems, of 5 different systems from 5 different countries? That's one. The second is the structural format of information itself. How do you manage, the integration of the?
Okay. Well, the integration work involves working with either a database owner or a vendor to map the structure of their data to the clinical data integration model, CDIM, to create a local source to CDIM mapping for the DNC, and to create a set of calls through the DNC to run the workflow through their API. And the third part would be any necessary terminological mappings, which depends on really what terminology they've got and whether that terminology has an existing common mapping through UMLS and a common terminology service, which if it does, then that's great. If it doesn't, obviously that's a whole other kettle of fish.